All right, so we've got an expert panel here, and I'd like you all to think of all those hard questions you've got around falls prevention that you might like to ask them. Does anybody have any questions? All right, I'm going to ask a question. So we hear about implementation and how hard it is to get from, our nice little world of well-designed research with carefully selected participants. How are we going to ever overcome the gap between research and implementation? Is it through co-design? Like, do we need to just be better at co-design, or is there something else as well? I'll open it to all of you.
I've got the... Is it on? Yes, it's on. So I think having the implementation science very early on in the project is a crucial thing. So before we even start doing the trials and the studies, we need to be thinking where it's going to be implemented, who's going to be implementing it, how it's going to roll out in the real world, so we don't get to the end and then worry about it. I think that's where I would start, with that real solid understanding. And then also understanding the financial, political, economic situation of society, and getting that health economics really embedded very early on as well. That'd be my two things.
Yeah, I wholeheartedly agree. When we design our interventions, whichever one it may be, we design it within a research setting, and it's a lot easier at least, to make sure that the person understands the intervention, that we follow up regularly. So it's important to bring along the person, but then we also need to realise that when it comes into clinical practice, we're not the one delivering it. So we need to understand the barriers around clinical practice, and that's where co-design comes in, and we don't do it enough. We haven't done it for a long time in our research. We're doing it more now. But the workforce is under such huge pressures, and we need to understand the pressures that you guys are in, so that we don't come up with an intervention that adds to those pressures, but it should release it. So having that co-design early on, as you were saying, is absolutely crucial. And also acknowledging that it won't be just one kind of blueprint for across all the services, or even if it is the same service but across different hospitals or across different, in the regions versus metropolitan, it will be different. So there will be a lot of co-design ongoing to make sure that it actually gets implemented, and that the active ingredient, if you want to call it, of a certain intervention doesn't get lost in that process.
I'll add just one more thing. Completely agree with Pip. I think you've got to have implementation embedded from the beginning of the project. So with my project, one of the people on that is actually an implementation scientist who, told me what to do, and I nodded and said, yep, this is what we'll do. But I think so I'm in the fortunate position that I have a position that is a joint position between the university and the health service. My office is in the health service. I rarely go into the actual university, but I'm really embedded within what happens at that health service. So I hang around with the physios and the allied health team. I sit on the hospital falls prevention advisory committee. So that I think that also really helps with the implementation, because as a researcher, I'm really, I have to really think about what's going on in the health setting, and it also helps bridge that gap between what's happening in the research world and then taking those findings out into the health service. So I think, more of these sorts of positions, I think, is also another great way, embedding academics in industry, or not calling them academics, embedding researchers in industry, I think is really important too.
I guess very similar things, making sure studies, trials are as pragmatic as possible, and that refers to who's recruited, to make sure there are not too many criteria to make it a select population. but also in terms of delivering the intervention to make sure that too is realistic and representative of what happens in the real world right from the beginning. So we don't just end up with model trials. We've got something that should be more practical and being able to scale up.
Okay, we've got a question from Slido, so we're going to go with that. So how do we promote falls prevention more? Awareness in the general population doesn't seem to be very high. Do we need to start in schools? Well, I can say we can start in schools. I'll just give one quick anecdote. My daughter went to a netball camp. I know it was soccer camp, and I got a phone call that she'd hurt herself and I needed to come and collect her. When I picked her up, she said, "Do you think I've broken my hip?" I said, "Sweetie, if you're walking, you didn't break your hip."
I think starting schools is quite interesting, but I also wonder whether we just need to really get into some publicity. What about some soap operas or some, television programs, or having those things really out there in the public is very powerful. If we could get into something that's a key Australian television program.
Maths.
I don't know one, but
Yeah, I just want to add to that as well. Like through the Australian New Zealand Fall Prevention Society, and also together with the CRE, which is led by Cathy, we're very much trying to raise the awareness on falls prevention in the community. And we're working with some famous Australians, some possibly like very famous on TV as well, and politicians too, ex-politicians. And I do think that is the way to actually raise the awareness, where people are feeling, knowing a person who is saying that this is important and that there's something that we can do about it, and also reaching out to politicians that they do need to help with funding the services and making sure that there is a plan to prevent falls in the community, and not just expecting that it will resolve itself with an ageing population, which it won't. But an awareness campaign is absolutely what we need to work towards.
There's Logan. We'll bring the mic over here.
Hi, my name's Queenie Stafford. I'm a health promotion officer at Northern Sydney Local Health District. We're all about prevention, promoting health. So I don't know if it's public knowledge that the New South Wales Get Healthy coaching service will now include more of an older person's health focus this year. It might have already started. It's a free health coaching service that people can ring up to get advice about exercise, healthy eating, and I believe it's going to start incorporating some falls prevention. So I just wanted to ask the researchers, how do you see this as an opportunity to embed some of the research that's been spoken today? How can we, maybe upskill the coaches that are giving out advice on falls prevention? Thank you.
I can quickly add to that, but it's they are reaching out to actually upskill the coaches in relation to research. So yes, it will absolutely be used as an opportunity for that. I think Anne Tiedemann has been involved, and just looking at Cathy to make sure that I've got it right. So yes, so the research will get embedded in that.
Okay, and there's another question from Slido. So are there learnings from other countries where fall rates in older people are lower that we in Australia should learn from?
There are differences, and the countries with the lowest fall rates are those in Asia, particularly in China, Southeast Asia and Japan, about half the rate. So it's a good question as to why. There are some differences that are pretty clear, factors like BMI and other factors related to health conditions. A study we did some time back also looked at attitudinal issues and looking at Chinese older people in Taiwan, in Hong Kong, and Chinese older people in Sydney, and a Caucasian group as control. And one of the issues that came out there was sort of like attitudinal issues and being more cautious and careful. So that was an interesting factor that came from it. When I heard people say that early on in my research, I just thought it wasn't really a factor at all, are we all careful or not. But I think there seems to be something in it, as well as just improving the person and their physical ability. Actually looking at attitudes and safety factors also could be an issue. It may be one small factor, but it was a difference. So that's the major difference. There's 18% fall rates instead of 33 or 40. So there is something going on.
And sorry, Steve, just to follow on from that, do you think it's different being careful to having concern? Because, you know, if we think about the study where we've looked at, you know, the stoic, the realistic, the anxious, the robust, those types of things, do you think it is different, like being careful versus being concerned about falls?
Yeah, I think you can be overcautious, and very much so, and, you know, where people are, you know, needlessly fearful, and that leads to the downward spiral. But there just also does seem to be this, you know, it's a different attitude, and I think careful is the only word I can describe in the way it might be. So it's something we don't want to scare people about the issue of falls and so on, but it's just another common sense approach in a way. So it's interesting.
Okay, and we've got a question from the back right.
Hi, my question is, how are we able to bridge the gap with populations that have cognitive impairments for the information, education, and then positive behavioural change?
In what setting?
I guess in the community, applying this type of knowledge that we've learnt today in populations that may be excluded in some studies because of cognitive impairment.
Okay, so there is some evidence we can prevent falls in cognitively impaired older people living in the community. So there's a trial in Finland, where that was particularly in Alzheimer's disease people, and then we did a trial in Sydney that was a combination of exercise and home hazard reduction. It reduced the rate of falls in those who had better physical function. And if we adjusted for baseline differences between the control and the intervention group, it reduced the proportion of multiple fallers. So there is some evidence, and there's also a Tai Chi study, I think, but the fall stats, when they excluded someone who had a really high rate of falls in the control group, it was no longer significant. So I'm a little bit careful about that study. So there is some evidence that we can, but it generally needs to be more of a supervised type program.
And the study too, Morag, involved carers as well. So
the study in Sydney was home-based exercise with caregiver supervision, or ideally caregiver supervision. Occasionally, depending on their functional cognition, they could exercise independently, but that was determined by the therapists. And in Finland, I think it was group exercise with they had 3 arms in the Finnish study. One was home-based, one was group, and one was control. So there is some evidence that we can prevent falls in cognitively impaired older people living in the community. Also some evidence, we did a subgroup analysis of people with cognitive impairment for the Sunbeam trial, and it was also effective in people with cognitive impairment. I think there was a question in the middle over here.
Just a question back to the point about differences between different countries. I wonder if any of the research is looking at livability. So my observation in Japan, when I visited there, is the pavements are wider. Older people are cycling to the supermarket. Older people are accessing the community way more than here. Once we give up driving here, people are very limited, and the pavements are not always well maintained. So I'm just wondering if that's something long term that contributes to our fall rate, is just that people are so contained once they have one fall, they're not going to go further.
Yeah, I'm sure that's other factors, like the livability, environments that encourage physical activity, safety in walking and moving around would be a factor. Quality of footpaths on the other extreme, all of these factors may well play roles, as well as behavioural things.
I thought there was some evidence from Canada I've got in my head about the accessibility of the neighbourhood contributing, but...
Not sure.
Any other questions? Yep, Cathy?
Great discussion. So with the guidelines, so the world guidelines and now the Australian guidelines, the approach has been to sort of stratify the interventions by sort of different risks. And we've heard, I think, today examples of kind of interventions delivered for those sort of different groups. So we've heard about kind of falls clinics. We've just heard about the kind of Get Healthy coaching service, which, might be more appropriate for those lower risk people, perhaps. So I just wondered what people thought about how we actually go about kind of putting that into practice and sort of matching the right people to the right interventions.
Briony. It's a good question for you.
Thank you, Morag. I think that's a great question. Thank you, Cathy. And you're absolutely right. Even if we were talking about, people from different cultures, and if you look at Australia, and we were talking about awareness, adverts and TV's campaigns in England are going to reach the English-speaking TV watching people, but our other cultures, and how do we actually raise awareness in different cultures where literacy, even in their own language, is sometimes a struggle as well. I think we also learnt today that it needs to be a very individualised approach depending on the individualised risks and the environment as well. So it's really understanding, I suppose, the different environments and those specific risks, and then identifying those strategies that we can really use, whether it be health coaching or environmental changes or strength and balance.
Putting your past experience in a health service at the front, how easy do you think it is to implement that kind of risk stratification and intervention from a health service perspective?
I think it's building capability with frontline staff to identify their risks, to look at their data, to identify where they need to improve and where their individual risks are, because one ward, for example, will be very different to a different ward. There's different types of patients, different types of conditions that bring with it different risks. So I think the key is really building capability in the workforce, in the front line, to really reflect, to review their falls, to look at their own individual risks, and to test strategies that might work, and the ones that work, then implement and embed them and share them with similar wards. But I think it really needs to come, and I think we've heard this from a number of talks today, from the front line, from the clinicians, and that really will help embed those changes and change that actual way we work and how we view risk and individual people. So I think it's about capability building, especially in sort of quality improvement.
I think there's also, when we're in Norway, they're doing a project of implementing the World Falls Guidelines, so let's see how they go and we'll learn from them. Cathy, do you have anything to add?
I think it is a really challenging problem, because partly also because of the way the Australian health system is set up. It's quite fragmented. It's, we've got some things that are, some things that are state government, some things that are Commonwealth government run. Not all of the programs talk to one another. We've heard about the different, programs that are not equally or equitably distributed. So I think we've got to work out a way of stratifying things, but then we've also then got to make sure that then the right services are there to actually, so that people can get into the program. So I actually think it's actually quite a big a big project, but it's why I think we probably need some sort of, national policy.
Yeah, and we heard from...
Can I just add something as well? Just really interesting that, I don't know when it was that Lucy Yardley wrote the Don't Mention the F Word. And we have had trials in the UK where participants have said they don't want it to be named as a falls prevention intervention. And I just noticed from today and talking to a few of you that actually we've moved on from that patients and participants and families and friends are starting to talk about falls and starting to actually allow the word falls to be in the intervention title or in the intervention. So I think we've moved on a long way anyway with the public perception of this, and people are talking about it a lot more. So I do wonder whether there is a lot more we could do in that lower at-risk group. Cathy, at that sort of public level, that population level, that we're maybe not really getting the right message out. I don't know how, but I just wonder, now we're allowing to be able to use the word, how we flood it get more of that word out there. So yeah.
And I guess, Cathy, just touching on what you said, so we had a presentation in the Aged Services concurrent session on ambulance, and there was Dr. Megan Ambrins, and she was talking about the difference between sort of rural and regional paramedics and the city paramedics and the difficulty with accessing services. And one of the services was a virtual service, and I was like, well, if the city people can access the virtual service, why can't the rural and regional people access the service? And it all comes down to funding outside our area.
Yes.
I think we've got a question. Did you have a question up there? I thought someone had a question.
Hi, I just wanted to ask a question about calculating falls risk, and I know we don't necessarily need to focus on a falls risk score, but I work in the community setting, and I'm just wondering, is the jury still out on the best falls risk assessment to follow? We use the FROPCOM, but I'm just wondering what the evidence says.
The community screening or assessing people for fall risk in the community is still a fine thing, because many people, there's very big range of function. Some people not at all at risk of falling. So it's not like in a setting in residential aged care or hospital where you assume everybody's at risk. It's not the case. So we do need to look at assessing people, and of course we want the assessment, as usual, linked to something you might actually intervene with. FROPCOM's fine, it got through early, and it's still, I think, might be mentioned in the new guidelines, but it's very strange, we've got all this far and we still don't have the single best set of prediction tests. Some of the work we're doing at Neuro, we're actually putting all of the screening tests together head to head in a very big cohort, and we're going to try and determine not just the idea that, there are lots of tests you can use, but actually recommend one or two. So maybe we'll have something next year.
I just want to add that the World Falls Guidelines have recommended the 3 key questions plus a physical assessment. So that is what they have recommended, but it's a bit narrow, but that's what's out there now.
I think we've got time for one more quick question, if anybody's got one from the audience. Otherwise, I'm going to hit the panel up for something. Yep, there's one. All right, I'm going to give you a wrap-up question to think about while we wait for the next question. What's the primary focus for falls prevention for the next few years? But we're going to go to the audience. I'm just giving you time to think about it.
I just had a quick question around educating patients in hospital. So I'm just wondering, on your opinion, is it best to go straight to the scare tactics, I guess like we do with the smoking campaigns, and basically just explain to them a simple message that a fall could potentially kill you? Might sound harsh, but I'm just thinking it's sometimes overwhelming in hospital with how much information and those kind of simple key messages.
I think it's a very individualised approach, and I think you need to pick your patient and understand their cognition as well. I think when we talk and do falls education, it's the why they're talking the risk factors. that lead so that there's an understanding. So, you know, if you spoke to a 23-year-old guy who's got his blood pressure in his boots and said, you're at risk of falls, he would probably look at you going, are you right? But if you explain that you're at risk of falls because at the moment your blood pressure is very low and you could faint, then it's a bit more understanding. So, and obviously that's just within the people that could understand the risk and the conversation and, you know, and then you've got the cognition. So I think it's, you know, it's about making them understand why it's a risk and the consequences of a fall. But I think you need to pick your patient a little bit and be a bit cautious around too scaremongering.
And I think there's current study underway by Meg Morris and Anne-Marie Hill, and it is, from my understanding, in talking to Meg, their plan is to actually develop some education material that can be disseminated more widely. Cathy, you look like you know what you're talking about more than me.
Yeah, so we're one of the sites that's going to be running the project. So, certainly I don't think we'll be advocating for scare tactics, but it's around I think one of the things, so we've actually done some workshops with people who've been in hospital, and I think one of the big things again is that people don't actually realise they're going to be at risk in hospital. So a lot of it is actually just starting that conversation about, you know, just making people aware that they are likely to be at risk of falls while they're in hospital, and then having a conversation about what it is that you can do to reduce that risk. So rather than being, you know, scary, it's about how can you keep yourself safe, what can you do to keep yourself safe in hospital. That's kind of it in a nutshell, but, you know, there'll be a lot more nuance in there, but I think that's probably the most important things that people often don't really realise, that they'll be at risk.
And it's nearly time to wrap up, but was there one more question? Yep.
Socio-economic areas. But are we going to see some more research done in those areas? Because it seems that I was in the community one, and one was done in eastern suburbs of Sydney and one was done in the North Shore of Sydney, some of the suburbs, whereas I feel like, you know, research and even putting posters up in Blacktown, in Fairfield, places like that, in pharmacies maybe in those places. Are we going to see that rather than seeing what's happening in Mossman and Woollahra and places?
Okay. For the people online, I'm hoping your sounds come back, but the first part of that question is when are we going to do some research in lower socioeconomic areas?
They've got the higher risks, yet all the research seems to have been done in volunteers from the eastern suburbs and the North Shore.
I will just quickly, so not Sydney-based, Melbourne-based, but our project is focused on the western suburbs, which is low socioeconomic, culturally diverse, you know, and again, the group of people that are normally not engaged in research. So, and again, what we've found so far is that it takes a long time to get things started because people... you've got to work a bit harder to reach people because of the literacy issues, language barriers, all of these things. But once you get them engaged, they are engaged. So, you know, we'll watch this space.
All right, I think we need to finish up there so you get out of my 5-year question. Does anyone want to hear the 5-year question? All right, well, we've had a vote. You voted to stay longer. All right, quickly, I'm going to start with Kim. What do we need to do for falls prevention in the next 5 years? Two sentence max.
Well, I think we need to raise awareness so that everyone is aware that we can prevent falls and how. By using exercises, and we also need to encourage the politicians to put in funding so that we can refer people to services, not just tell them what's good, but that they actually know where to go.
Steve?
Very quickly, incorporate reactive balance training into our exercise programs to see if we can really make a big difference in preventing falls.
I think we should broaden out our horizon and bring in more researchers from other disciplines or more social care areas and public health areas to expand our falls understanding and how people fall.
I've got my microphone, thank you. Oh, gee, this is tough. I think focusing on how we can actually implement what we already know into practice, but I also think we need to think about what else we can do that's a bit more innovative as well. And so I think that does bring in things like the reactive balance training, digital technologies, but we've got to make sure we don't leave people behind.
Our focus is to improve the efficacy of exercise interventions. So there are many challenges in the reactive balance training that I have introduced this morning. So I would like to find the key essence that we can implement into a clinical setting.
And I'm thinking more hospital-wide, just more engagement and awareness of medical staff, maybe in the non-geriatric and that sort of thing. So cardiologists and surgeons and things, and actually making falls in front of mind. We talk about de-prescribing, but is that actually in their frame of reference? So,
Great, thanks everyone. And Steve, do you want to give a quick?
Thank you, Morag, and thank you, the panel, and thank you for all of the speakers today in the morning sessions and the split sessions this afternoon. It's another jam-packed meeting. When you look at the quality, it's like, it's not too different to the World Fall Prevention Conference, to be honest. It's lots of interesting talks. Thank you very much for coming. This was the 32nd, as we understand, network meeting, and so we'll leave it there and hope you all come back for the 33rd, and have a good evening. Bye.